go ahead and get started. Good morning, everybody, and welcome. My name is Hugh Brady, and I am the past president of NAMI, Illinois, and currently the chair of the NAMI, Illinois Legislative Committee. Today, we're here to talk about the new 988 crisis response system and how it's going to roll out at a very tiny level and hopefully grow over the next 4 or 5 years. And one of the things we want to talk about is the danger of over-promising and under-delivering. So just a couple of housekeeping reminders. If you have questions, please put them in the chat. And after each presenter, each section, then we'll go ahead and answer some questions and then have an open Q&A section at the end. Just introduce our panelists today. We've got Hannah Wesolowski, who's with NAMI National. She's the Chief Advocacy Officer. We've got Rachel Bagwat, who's the Director of Policy for NAMI Chicago, which is our state's largest affiliate. And Andy Wade is here. He's the new Executive Director of NAMI Illinois, which is our statewide organization. So you may have heard a bit about 988. It's been in the news. Some news stations have made it into a big deal, which it could be. But on July 16th, it's going to start. It's going to be launched, but at a very small level. That all that's going to happen on July 16th is 988 is going to connect people to a suicide prevention hotline, and it's not going to be the huge comprehensive crisis system that NAMI Illinois really should have, or that everybody in Illinois should have. We've been getting a lot of questions, and what we want to say is that 988 is kind of a work in progress. We're going to give you today the best answers that we have right now, and hopefully give you some information about how to handle questions that come from your members and from people in the public and so on. Eventually, when the 988 system is up and running at its full-blown step, system, it's going to be really wonderful. But what we need what we need to get there is, number one, somebody to call, so that when somebody dials 988 any time of the day, any time of the year, somebody who will answer the phone, and it will be a trained responder. Someone to call are really going to be the first responders, people who are can help out with people who are in mental health crises. Then if the person on the phone isn't able to resolve it, then the second thing we need is mobile crisis response teams. Teams of 2 or 3 people who would be mental health professionals, who would be actually able to go to the person who made the call. And this would have to be coordinated with 911, because sometimes, if a mental health crisis does need a law enforcement response, somebody's a danger or has a weapon or something like that. And it has to be coordinated with 911, because sometimes somebody might call 911 and it doesn't need a law enforcement response. It just needs a mobile crisis response team, a social worker, a mental health professional. And then if the crisis response team isn't able to resolve the situation, then the third thing we need is a place to heal, some place to take the person who is having the crisis, where the situation can be stabilized and the person can be set up with various treatment options and so on. And then here in Illinois, there's a fourth thing we have to be concerned about, and that's the need for a sustainable system of funding. The initial startup money was done with federal money out of the COVID crisis response legislation, and we all know that's not going to last for more than a year or two. And so what the General Assembly needs to do is to figure out some way to fund it permanently and at a high level, and so on. So we've got a system up and running. We'll have a system up and running in 4 or 5 years. So the question is, how do we get there? So Andy and Rachel will talk a little bit about what's going on currently and talk about how we need to communicate with our members and the public. And then Hannah will talk about some of the recent examples of from other states, and don't get too jealous. And then we'll all talk about advocacy, and it's going to take a lot of advocacy to get from where we are to where we ought to be. So let's start out with Andy and Rachel. Take it away.
I think we're going to go to Rachel just talking about the current state because we're in the game and starting behind, but NAMI Chicago's got a really great call center, so they've been paying attention to this for a while. So Rachel, you want to just talk about where we are right now?
Sure. Good morning, everyone. So an important thing to know about 988 as it rolls out is that although 988 was a national mandate, it was dictated by the federal government that 988 needed to roll out across the country on July 16th. Each state was given the responsibility to really manage the implementation in their areas. And so the 988 as a call line is being built on the foundation of the National Suicide Prevention Lifeline. And what's important to know is that when you think about that and you think about other infrastructure that exists, in the mental health crisis system, what that looks like, what the current state of that is very different in different states of the nation. And unfortunately, especially when you look at the call center piece of this, Illinois is starting out behind. We, believe it or not, in the beginning of 2022 and all of 2021, Illinois had the lowest in-state answer rate in the nation for the National Suicide Prevention Lifeline. And what that means is that in the first quarter of this year specifically, I'm sitting in Chicago, right? If I were to call the National Suicide Prevention Lifeline here in Chicago, there's an 80% chance that the person who would end up picking up my call would not be in the state of Illinois. And that's because we don't have enough call center capacity in this state. What that also means is that in order to find a call taker for me in the different National Suicide Prevention Lifeline call centers, my call would bounce around, sort of start in Chicago, then try the call center in DuPage, Lake County, the whole thing. And it could lead to significant wait times on the National Suicide Prevention Lifeline. So that has been the current state of what we call the NSPL in Chicago, or I'm sorry, in Illinois, not in Chicago. And it's important to understand that context because 988 is being built on that foundation, and Illinois has a big job to do to get to a place where our 988 system is comprehensive and really can answer all of those calls here locally because we are starting out behind. And so we are doing the work. I think there's a lot of hope to be seen in Illinois. We're talking about what this soft launch will look like on July 16th. 988 will go live on July 16th. Just an asterisk here to say that it is not available right now. Do not call it right now. It's available starting on July 16th. And you will be able to dial those three, easy digits on your your phone and access the National Suicide Prevention Lifeline. But what we know is that the planning processes are really still in the beginning stages in the state of Illinois. We did have an investment in about $10–15 million of federal pass-through money going to our call centers. There's also been about a $5 million investment by the state of Illinois in 988. A lot of this money has gone to one statewide backup center, which is located in Bloomington. It's being operated by Past Crisis. But even with that existing funding, we know that this will not be enough for the way that call volume is projected to grow. We also know that the best practice, and we'll talk more about that, coming up, is a really robust hyper-local network of call centers, and right now Illinois only has 6. There's also simultaneously, when you step back and you think about those 3 levels of crisis response that Hugh talked about, the state is also doing some great work in investing in mental health specific mobile crisis response. There is a grant, as most people know, called 590. The state invested $67 million this year. It's going fully live this summer. Just adding more mental health clinician and peer-led mobile crisis teams into the infrastructure of Illinois. And so, that capacity is building, but again, there's going to be a lot more work to do after this July to really kind of build that up. Many people have talked about the 988 trust fund bill, which was running in this session. It didn't pass as is. It actually got integrated into Illinois state budget. And a lot of people said to me, well, that's great. We're funding 988, right? Sort of. It was great to get it through. What that bill does is it creates a repository, like a specialized repository, in the state sort of treasury to hold 988 funds, and then the state did put $5 million into it. So it's a start, but it doesn't solve the issue long term. And then the other thing just really important to know here is the beginning of the implementation of CESA. CESA is the Community Emergency Services. No, I'm going to think of what the acronym stands for, and I'm going to put it in the
Community
chat.
Emergency Services and Support Act.
Thank you, Andy. I am the worst at thinking of what acronyms stand for. It was an act passed in 2021. And I think it's a really important act. I've been jokingly calling it the Get Illinois Organized Act, and it is starting to roll out on a statewide level right now with one statewide planning council, and eventually there'll be 11 regional planning councils in the state. And what those councils are doing is they're essentially getting together every stakeholder that could possibly be in the mental health crisis response system, putting them in the one room and saying, let's make some rules. So when a person calls somebody in a mental health crisis, there are rules and standards and easy guidance for who responds, what kind of response is allowed, and to coordinate between systems. So what we're seeing is that a lot of new exciting programs are rolling out, but the coordination is still coming. And so we're going to have to be really cognizant of that as we message and as we utilize these services going forward into the summer and beyond.
Right. Okay, so one of the things that we've seen, and we every month we sit on calls with other parts of other states that are working on this. This is rolling out in every state. It's the same thing, but it's rolling out, according to where each state stands. Many of our PR materials, the kinds of things that you would expect to have, they're not out yet. As many people know, SAMHSA was discouraging public communication until closer to the deadline. I know one thing that we are seeing is that the media is already covering it. And that's one of the reasons why we wanted to have a messaging conversation, just so that we would have answers to the basic questions to the extent that we can. We're not the state of Illinois, and so we can't speak for the state of Illinois, but we can each speak for our own organizations. The people in the NAMI communities and Mental Health America, the people on this call are the folks who are will get the questions from the community. So it's important that we be on enough of the same page that we can have a conversation continue to have conversations over the next couple of years, because what happens on July 16th is really just the beginning. And that's an important point to make when we're talking to folks, because if the expectation is that on the July 16th we're done, the momentum and the support that we need to build a vision for a complete, comprehensive crisis response system won't have as much support. So we have the opportunity now, with this moment in time that's coming up, to begin talking about the system that Illinois needs. And as Rachel was pointing out, we're behind. And so we need to begin building out all four aspects of the story. So one thing I would ask people to think about while they're on this call today is, what stories do you have that match one of these pieces of the story? Because as we begin building public support for a comprehensive, complete, robust crisis response system that will be built over several years, people need to begin understanding what that actually means, especially in areas where we don't have the resources that we need, or the system is not quite built out yet. As advocates, we know that when things aren't completely done, it can be kind of frustrating. And the fact is that 988 is a work in progress. 911 took decades to get to where it is today. So it's important to remember that this is a good thing. Even though it would be great if all the pieces and all the vision was there, that's not where we are right now. And so the words that we use when we talk about it do matter. Right now, we want to sell the vision, what 988 and the entire reinvented crisis continuum could look like in Illinois to really serve everyone. But we also have to manage expectations, and that means managing the stories. So I just quickly put together here, and then in the following slides, we go through each one, the sort of high level, how to say it kind of stuff. I do think that this will evolve. We've been collecting materials from other states as DHS begins to get they're beginning to do focus groups that are targeted communications for various constituency. We will love to be helpful to that. But as the story gets rolling, we need to be on the same page enough that we're selling the same headlines of the vision of what it could be. And, in all of our own work, we're going to be developing our piece of the story. What we're looking to do is begin building a sort of a drumbeat campaign, kind of beginning in July, once the number goes live, that really teases out the full picture of the story. So if you have stories that fit one of the pillars, that would be something to follow up with it on, because we're working on getting media training and all of that kind of stuff. So anyway, looking at the 3 pillars, and the 4th one we've added in Illinois isn't really part of the national best practice message, but it's kind of ours. When we talk about something to talk about, someone to talk to, the vision is a call that's answered by, nope, go back. The vision is to have the call answered by trained Illinois people who are directly connected to all resources. This idea that this is the front door for mental health. We're just not there yet. A way to say it is that turning on 988 will make it easier to reach an improved NSPL system. That's a good thing. Building the connections to mobile response, 911 dispatch, that's the work that lies ahead. These are where people are probably having the most misunderstanding. And so it's important that we be paying attention to where it actually is and talking about that. We do need to do this right. And that takes time and commitment. If people are wondering why it's not turning on and not done in July 16, it's important to remind people that it took decades to launch. I think 20, 30 years before 911 had the penetration where it's essentially universal. So we've got some time to work on this. Someone to respond is another piece of the story that key elements are there, but it's not a system yet. So the vision is every mental health crisis gets a mental health response immediately where it's needed, and that the people who are responding know what to do, and we're not over relying on law enforcement and other first responders. The integrated system of systems, the system of partners, that's the vision. That doesn't exist yet. Right now, the way that we're talking about it is saying that those teams are gearing up now. That's the 590 teams. When you're talking to the public, the jargon is not going to mean anything, but the mobile response teams are gearing up right now. The integration of those teams with 988 and 911 hasn't happened. So while there is a good list, and at the end you'll be able to tap into that list of all of the Find Vanity programs across the state, it is not connected to the system yet. So we don't want people to believe that if they call, that they're calling into a connected system yet, because that would be misleading. But that can be a kind of an unsatisfying message. So it's important to just let people know that people are working on it. There's a lot of great stuff that's in motion. The fact that it's not done yet means that we're going at it the right way, which is we're taking a soft launch approach and building the pieces as we go, and not overpromising. The third one is a good example of that, because if the vision is every community has crisis stabilization centers and anyone can access whatever follow-up care they need, we don't have that yet. We know as advocates that Illinois has an acute shortage of not just beds, but all treatment choices. We know that ERs and jail cells have become mental health treatment centers, which is not appropriate. And sometimes people will be in the ER for 3-4 days before they're able to get treatment. They call that, I think they call that boarding, but that's not the answer. So many people in the regular general public won't know that. That's a basic fact that we all know that we might be taking for granted. If we are talking about problems, all good messages also have sort of a future and a solution. We can talk about proven models like the living room right now. Living rooms are drop-in centers. I think many of you know about them. Many of our NAMIs operate them, where peers and people with training to manage crisis situations are able to help people, one, recover, get peer-to-peer support, and also access services as we need. So there's a lot of good examples out there, and this is something that we want to be talking about, but that's not the universal answer. We need options for every level of care, whether it's hospitalization, outpatient care, peer support. I think this is the time to talk about the system that we want to see. Everybody is talking about mental health right now. We know that everybody, that wait lists and access to actual care services are very unequally distributed. So this is the time to talk about the scale. A place to heal is a place to heal, but we're really at the very beginning of this. Finally, I mean, not everyone's going to want to talk about funding. We don't expect that this is going to get real action until after the election, but we know that sometimes there is a tendency to believe that the investment that might sound like a lot of money at the front end is where we are. So sustained funding, permanent systems, integration, that's a big ticket item. So the seed funding, which is how we're talking about the money that's out there now, that's a seed investment, but it's at the beginning. So as we talk about money issues, we want to talk about sustainability. We want to talk about funding that matches the actual need. One thing that is kind of out there is that we don't exactly know how much and how big it needs to be yet. We know that it needs to be much bigger than it is right now, but they're just beginning to do the measurement and the local estimation that's going to tell us what the ultimate price tag is, but it needs to match the need. And I think the other piece to make sure that we get into our conversation is that we're supporting all parts of the system and not robbing Peter to pay Paul. I know, the story that was out, and it appears to just have been a mistake. Something needs to be fixed, but we're not going to rob 911 to pay for 918 or 988. We need all pieces of the system. So the words that we use matter, and we want to talk about things that we're doing that illustrate one or more of the pillars. We're selling the big picture as an advocacy community because that's going to take some time to achieve. But we're talking about what's happening right now in its embryonic state as a positive step forward. All right, I think we're going to go into each one now. Rachel, you ready?
Absolutely. Thanks, Andy. Andy shared such great context here about kind of those three pillars and the messaging. And, something I want to add to the topic of saying that we all need to get on the same message here and that words do matter is that we recognize as mental health advocates who do so much work in the state that there's been a little bit of an information void about 988 and about other new crisis programs in the state of Illinois. And some of that has been by design for a number of reasons, and some of it hasn't been. But what I know is that, and what we know is that in darkness and in information voids, rumors and misinformation spread, and stress and frustration spread, right? And so in so many of the advocacy rooms we sit in as NAMIs, we hear both a lot of good questions about 988 rollout, but also a lot of frustration and a lot of existential questions about it, right, as well. And believe me when I tell you that I can relate to that, right? I spend a lot of my time thinking about these issues, and we have our own, advocacy goals and concerns. However, it is so important that by the time that 988 rolls out, we as advocates and providers and leaders in this space are really on message and hopeful and clear, and about the rollout. Because if we all come into the room saying, well, we don't even know what's happening with 988, that's not the message that we need to pass along to the people that we serve, right? And so I think we need to hold ourselves accountable for understanding the basics of what's going on, and also for projecting, like Andy said, that message of hope, but also that message of that full vision of a crisis system.
One thing that happens when people are communicating in the dark is there's a tendency to kind of fill in the blanks. I mean, we want to sell the vision, but we are not at the vision. It's really important that we say what we know, and that I don't know, or it's not done yet, or that's the next step. Those are perfectly valid answers. So while we'd love to have, a complete message guide that's got everything answered, a good answer isn't necessarily saying that the issue is resolved. It's just a good, positive answer.
That's such a great point, Andy. And with that in mind, as I go through, I'm going to go back through the 3 pillars, or actually we'll go through 4 pillars, but the 3 pillars of the crisis system that Andy just talked about. And I'm going to share first, what's the overall question here? What's kind of the best practice vision? What's actually happening in Illinois? And then what's kind of the tagline, right? Like, what's the party line on this? And so I'll try to go through these slow, because I think this is really, really important. So the first level, right, someone to call. The question is, if I am in crisis, or someone I know is in crisis, I pick up the phone, and what? What do I do, and what's going to happen when I do, right? And that's a really important public-facing question. So I'll tell you that's the question. The best practice is that every mental health emergency call could be answered locally. 988 could initiate immediate mobile and crisis response if necessary, and that there would be integration between 911 and 988, because what we know is that even when 988 is fully built out, people will still call 911 in crisis. That line will still exist, right? So we have to have that coordination, so that there's no wrong door. Regardless of which one that you call, you'll be able to get the safe and appropriate support and response that you need. An important thing to know here in the best practice is that research and existing programs show that the majority, unlike 911, with 988, the majority of phone calls will be able to be resolved on the phone. A lot of people are looking for emotional support. They need to do some safety planning, whatever that might look like, right? And so 988 doesn't primarily act as a dispatch in this world. It primarily acts as a support number, but it should be answered locally, because there is a need to coordinate with local resources for folks to really, stabilize and connect people to support, and there needs to be that coordination. So that's the big picture. That's the best practice that we have to move towards as a state. The reality is, it'll roll out in July 16th, and not a whole lot is going to change from the National Suicide Prevention Lifeline in Illinois, other than a 3-digit dialing code. And so the answer to the question, the party line answer to the question from a messaging perspective, on who do I call if I'm in crisis, is right now in Illinois, as of July 16th, you can continue to use 911 for anything you would currently use 911 for. In addition, 988 will be an easy 3-digit dialing code to access the National Suicide Prevention Lifeline and suicide and crisis response, support services. And so I think that that's important to know, that both are still available as we kind of move forward. And again, that may change as we continue to build this system over several years. Next slide. All right, so the big question for the second slide, the second tier, is if I need someone to come out to me if someone comes out to me to resolve mental health crisis, who's going to come and what's going to happen? So the best practice here is that we would have a fully covered statewide network of rapid response teams. So you would have a variety of options available. So you'd have mental health mental health clinician and peer-led teams. You'd have teams that could utilize ambulance or police as needed, but that anywhere in the state you were, you would be able to get the safe, appropriate response to the type of crisis that you have, and that would be integrated both with 911 and 988. What's happening, as we shared in Illinois, is that we are increasing the types and quantities of teams that will be available for a mobile crisis response starting in July, but that coordination doesn't exist. And that's, again, where CESA comes in, is that if CESA goes as planned, by next year, this integration will happen. One of the other advocacy needs there, though, is really looking at statewide coverage. There isn't equitable statewide coverage right now, and so there's an advocacy goal needed there. But the party line here, right, in terms of what's going to happen if I call for mental health crisis, is that there are many different kinds of teams that can respond to mental health crisis, and that coordination is coming. Next slide.
The one thing, though, I would say, though, is the 590 teams do exist. So they're building, they're already funded mental health clinicians across Illinois that work on that. So the teams are, the organizations are in place. At the end, we have a link to where you can just get the full list. But that's one of those things where if you're a local NAMI or you're a local advocate, that's a good thing to have on your website. Because we shouldn't not be using them. We just don't want to promise that everything is connected. This is a devil in the details kind of business, but there is support now. It's just not coordinated yet.
That's a great point, Andy. And so it is possible to deploy any of the 68 590 programs teams. The difficulty right now is they have 68 different phone numbers. So we're working towards a vision in which they would be able to be centrally deployed, and one could access whichever one was most appropriate via 988 or 911. We don't want people to have to look at a 68 phone number list, right? Or look at a service map. That shouldn't be the responsibility of someone in crisis. But to Andy's point, they are available and they provide great response. So the last piece, a place to go, the question, I need help right now. I want to be with someone right now. Where do I go? And the question that I ask as an advocate is, what would it really take to have mental health focused spaces that could act as a true alternative to an emergency room for somebody in crisis? And there's so much that requires. It requires 24/7 capacity. It requires ability to handle police and mobile crisis team drop-off. It requires the ability to handle any level of acuity or need. And that could be a continuum of different kinds of spaces. But this is, from my perspective, this is the level that this is the level of crisis care that our state is not really talking about right now. There's a big national conversation about call centers. There's a big national conversation about who responds to a mental health crisis. And the one that we're not really having is, then what? Where do we go? And how do I get support and stabilization long term? And so I think the party line is there are some services for this available that are mental health specific in Illinois, but we have a long way to go to build a comprehensive system. I'll pass it over to Andy.
Oh, okay. I was just answering a question in the chat, which Lori had, which is, am I understanding that on July 16th, 988 will only handle suicide prevention, not other mental health crises? No, it will. It is not just suicide prevention. I mean, there is expansion, and the difference is the systems and the connections aren't established yet. And because we have invested in only 6 centers and now a new statewide backup center, the likelihood that you're being answered by somebody who's in Illinois, who knows Illinois, is lower. So, but no, the system is not just for suicide prevention. Just to give you a sense of why it's important, or where we stand in terms of being able to answer calls locally, I was on a national call last week, and someone from Ohio was in there talking about, only 20 call-ins or 20 centers, and Ohio actually has 2 million less people than Illinois. So scale is an issue, but no, what happens, the 988 number will not just be for suicide prevention. So,
and I just jump in and say it's really important to have the call centers local because they know the local resources.
right.
Whereas if you call the big center in Bloomington right now and you live in Lake County, the
Right.
Bloomington folks probably don't know a whole lot about what's available in Lake County.
Right. Or if the call is being answered in Wyoming, they're going to look at the list and it's like, oh, hey, there's something in Evanston, Wyoming. There's 2 Evanstons. They're not going to be able to understand. I mean, people are trained, and the system is, it's a good system. It's just not, it's not adequate to the vision and need for Illinois yet. So, just getting at sort of the what does it look like in terms of the underlying funding structure. We'll cover this briefly and then have a little break to ask, for discussion. Then we want to have some examples from Hannah, because some of the states around the country are doing some really interesting work. And while we are behind, every state is struggling with this. And, we're behind. We're not that behind. I mean, this is one of those things where Illinois is catching up from years of neglect in our behavioral health system. But the commitment this is the time. So, when people, it's important that we talk about this because we do need to get the dollar figures in the sustainability issue addressed, this is what next session is going to be about. So the 988 Trust Fund is just it's a structure. As many of you know, Illinois has this history of sort of fund sweeps when it's the end of we need to balance the budget and there's an untapped pot and we borrow from it. Yearly budgeting and the politics of all of that is something that a permanent system cannot have. So the structure exists to protect the funding and distribute the funding, but it's got some seed money in there and that's about it. So the down payment is good, but we need to be able to match current demand, which we're not able to meet. The infrastructure and integration of that infrastructure still needs to be built on a much larger scale. And the other piece is that once this gets out there and we do begin a large public conversation and 988 catches hold in the public domain, it's going to grow. We'll see a lot higher volume. So that's what the funding structure needs to consider. What other states have been looking at, or what, telecom fees, that's how 911 is funded. Some states have got that in. I actually think that list is probably out of date by now, but that is a conversation that's being had across the country. Other states are looking at how do we use the current health insurance, public and private, to, how do we cover this just like other emergency services? So why should mental health be different? So understanding how we tap into insurance, and as we know in the mental health field, parity is a huge issue. So that's not just going to happen. The other piece to get out into the funding conversation is that the system that we're sending people to, the treatment options, pillar 3, a place to go, that is, it's been neglected for years. And so the build out on that is a large, long-term issue. That wouldn't be handled through the trust fund, but that's something to make a point of. So the other is just not competing, having one system compete with the other. That's just one of those things that could be a distracting conversation. It takes people off message, and it's just, as advocates, we need to protect against that because it does happen, but those are fixable problems. I think that we want the public to understand that an integrated system, we need an integrated, fully funded permanent system. So we have a little time, so I think we were going to break for just, are there questions or discussion points? And then we'll have Hannah talk about some of the other what's going on in some other states.
I have a question.
Sure. Hey, Bonnie.
Are starting on July 14th, are we,
16th. That was
I
my
mean-
mistake. Sorry.
it was my kid's birthday on the 14th, so that's going to stick in my head. On the 16th, are we to advise our clients that 988 is an option for them to call? Or should we keep them calling their provider, NAMI, threshold, whoever is serving them currently, and not use 988, but continue to use 911 in the interim?
No, the 988 system will be on. I know one of the kind of confusing things that's happened in the national conversation is the idea of don't do anything until the 16th. What they mean is don't send calls over to the 16th. Don't jump the gun on the announcement. But what happens, I mean, 988 will go to the, suicide prevention and crisis response system. And so we don't know, if we encounter quality issues on a massive scale, maybe we don't want people to go there. But right now, no, 988 is a good thing.
So they can call 988, but chances are if it's a 988 place out of state that doesn't know the area, it's
Well, they'll
going to
have
be
the
shipped
resources.
over to 911.
They'll have the resources and they'll have trained, staff responding who know how to manage the situations. It would be better if it was in Illinois, but it's still appropriate to send people to that. Rachel,
Okay.
what do you think? Chicago runs a really great call center that's not
Yes.
part of this system.
Yeah.
What were your
I
responses?
think the answer I would say, Bonnie, and it's such an important question, is you should use as of July 16th, if you would send your clients the National Suicide Prevention Lifeline as a resource, then you can send them 988 as a resource. Because we have to remember that they're projecting that 80% of 988 calls will be able to be resolved on the phone. And why we say that is because a large part of operating like a suicide prevention lifeline or even a helpline like NAMI Chicago does is really providing emotional support, validation, and sometimes safety planning on the phone. And so that can be done. It's what you shouldn't try to do on July 16th is to use 988 as a dispatch line. Don't call them because you want first responders to come out, right? That's not what we should use it for. But if you think about it, like so many of the other crisis or emotional support lines in the United States, I think you can use it as you would use a phone line. Does that make sense, Bonnie?
Yeah, so it's more like a warm line for now that will provide somebody caring on the other end that is knowledgeable, that can talk to you. But should you need anything more concrete in terms of response, will they then transfer you to your local 911?
It won't.
They are able to. They are able to do so, and also in the event that a 988 call is picked up in the state of Illinois, for example, in the statewide call center in Bloomington, they're working really hard to build up their statewide knowledge. I know they've worked with us directly. We just worked with them yesterday to do a whole presentation about the crisis landscape in Chicago and Cook County. So it is possible, right? Like they will be able to deploy 911 as needed.
That was my bottom
Yeah.
line, is will they be able to deploy 911? Because if they're just a conversation and then the person in crisis needs to make another call, that's double the risk. So I just wanted to make sure that if I say, so right now it's, since we don't have enough places to heal available in Illinois, it's more of a warm line. More severe crises will be transferred to 911.
Well, I don't know. I wouldn't call it a warm line. I think it's a crisis response line.
I use the
think the
term warm
difference
line
is the
because it's
dispatch
just
capacity
somebody
is
to talk to.
it's going to be, these are trained people. It will be a quality system. It's just not to the girth that would reach our vision, and a lot of the mechanical connections don't exist yet. But they'll be talking to people who understand that if someone is saying words that indicate that they're in imminent danger, they know that the call needs to be handled differently. So I
Excellent.
think that you can,
I wanted to make sure that that
right.
chain of responsibility is in place, even though all of the aspects aren't.
Right.
Yeah.
Well, the other, I just looking at another question, which is what are the suggestions for areas that are behavioral health deserts? And that's a real issue in Illinois. It's a real issue in certain parts of the city of Chicago. It's a real issue certainly in our rural areas. And, you know, one thing with rural mental health, and this isn't figured out yet, is, you know, the distances are greater. You know, it takes longer for a crisis team to get there. I would suggest to everybody that is, you know, this is not a public call. This is a call for advocates that are already involved in mental health in your community. And so knowing your local resources, I would say accessing that 590 list of the funded 590 organizations that are near you, and knowing that will be helpful, because a lot of things don't need to go to a crisis center. The warm line in Illinois still does exist. You know, it's a good thing. If you, and we can follow up with this in the mailing that we send out, we have a cheat sheet of all of the current, there are a lot of different one-stop shops. There are a lot of different resources. It needs, long term, 988 will become the 911 of mental health. But right now, don't stop using the local resources. And I would especially urge local NAMIs to get your websites up to date so that you can link to the resources that you have. Rachel, anything else to say on that? Or Hannah, has that been coming up in other places? What do you do in deserts?
Answer Ashley's question, and then Hannah, I know you had something to add too. So Ashley, your point about behavioral health deserts is so important, and this is something the state is working on right now. Really looking at mapping what is the current coverage of 590 teams, as well as other types of crisis resources. That's also an important part of CESA. The reason that CESA, the organizing work is being built, has been being broken into 11 regional councils, is to really look at different geographies in the state to look for gaps and different needs and resources. So I think that your question is so important as an advocacy question, because I think once we understand the landscape of what those maps look like, of where the gaps are. I mean, we know, I know in Chicago where the behavioral health gaps are, but I need to see this on a map. Then I think if we need to advocate for funding or for program expansion, we take a look and say, this is an equity issue, right? Let's take a look at where these gaps are and how they need to be filled.
Rachel, we got a couple other questions. Hannah, did you want to jump in on that?
Yeah, I mean, the only thing I would emphasize is what you said, Andy, that this is more than a warm line. These are trained crisis counselors trained to de-escalate crises that are answering 988 calls. And actually having this available everywhere, as Rachel said, they can resolve 80 to actually estimates up to 95% of calls over the phone. So it actually reduces the need for in-person response. Local call centers are so important because they can better connect people to local resources after the fact. But yes, every 988 National Suicide Prevention Lifeline call center can connect people to 911 wherever they happen to live. So an important question that you asked, Bonnie, but yes, 988 is going to be able to provide that de-escalation over the phone, but also connect with 911 if a dispatch is absolutely needed.
Excellent.
There is a question about text, and the answer is yes. And then there was another question about funding for living rooms. And is there a list of living rooms in the state? I know that living rooms has been, you know, have been RFPs that have gone out increasingly. I don't know if there's a master list. Rachel, do you know? And actually, we have some folks from, I think we have some living room providers on the phone.
There is a list on EHS's website. We can share that as well.
Yeah.
Certainly. And then just to quickly hit Ashley's question.
But in terms of increased funding, I think that's part of the questions to continue to raise, because that would be, in terms of what exists right now, you know, this is a scale issue. But I think it's mostly grant funded. So getting the list out, but this will be an advocacy issue.
Yeah. And then Ashley had an additional question here. So this would be just referrals to other crisis, not outpatient treatment. So this is, again, one of those questions between what's happening right now and what we think the vision of 988 should be. So in a fully funded comprehensive system where 988 is really, the front door to a comprehensive system, a hyper-local 988 call center should be able to support people in crisis, but should also be able to, with follow-up calls and et cetera, be able to work through connecting them to local resources. But there's not full coverage to that for that right now. I think, most of what will be provided starting in July will be kind of that on-phone support, and then, connection to crisis resources if it is warranted due to the level of crisis.
Right. So thanks, Shelley, for putting up the yourlivingrooms.com. We'll, when we go through this event, we'll add to our list of links that we send out. And thank you, Hannah, for clarifying how texting works, that it will be available, but it's not routed yet. So it'll be answered, but again, just like the rest of the system, it's not completely done yet. So.
And I would just add that I think it's going to be important to kind of come up with a standardized definition of what you mean by living room or crisis response center. Because some living rooms are just places for people to go and kind of chill for a while, and other places are using the term living room, and it's really a full-blown crisis response center. So I think that'll have to be clarified as well.
One thing that I would say, we're not the state of Illinois. We're doing this because the questions have been coming so fast and furious that we feel like people need answers. There is the 988, I forget what they call their big tent thing that meets on an occasional basis, but there's a meeting of the 988 big tent thing next week, and you can go to the DHS website and see that. I would also, the public messaging subcommittee is really beginning to get going, and one of the things they're going to be doing is focus grouping. They're focused on how do we reach different constituencies, but what Hugh brought up of what's a living room, what are the different options on that, we know that in the mental health community, jargon proliferates, but we have to, this will be a good one to make sure that the materials that come out address is talk about this stuff in an easy to understand way. So any other, or should we go straight to one more before we go to Rachel or to Hannah? I think we're good. Wait,
I'll answer Lisa's question in the chat, or Mary Ann's, and then maybe we can jump to Hannah, because I'm sure there'll be some questions after we hear the best practices.
Right. Yep. Okay. Thank you, everyone, and thank you, Rachel. Thank you, Hugh. I'm really glad to have Hannah on the phone. We participate in the national network of different states that are working on things, and one of the things we're probably going to do is grab sort of a greatest hits set of materials and proposals that we can begin learning from here in Illinois. And we all know that if you want to motivate an Illinois legislator or Illinois person to do something, show them what New York is doing better. So I will hand it over to Hannah, and thank you for coming out.
Yeah, thanks so much for having me. It's great to see all of you and be with you today. One thing I just wanted to start with, Andy, you said we're behind, but we're not behind. And I think that's an important point, because every state has a lot of work to do. Even states that are in a good place still have work to do. And it's because this July 16th deadline was set by the Federal Communications Commission for telecommunications companies to direct 988 calls to the National Suicide Prevention Lifeline. So it was a 2-year turnaround, very fast. And this is a lot of work to do to overcome years of underfunding and patchwork services that were available. So, and every state isn't starting in a different place, in communities even, because they have different crisis services already available, different ways that emergency services operate and cooperate. So it's a different approach in every state, but I'm going to pull out some highlights and things that I think are interesting as you all advocate here in Illinois to think about. And I will also note that you can visit reimaginecrisis.org/map to see links and an overview of what states are doing, how much they're investing. But again, I'm going to dig into some of the top line examples. First up is Georgia. So Georgia predates 988. The system has actually, the Georgia Crisis and Access Line has actually been around for a number of years. And it is a centralized line for residents to get mental health crisis services. So much like 988, it has de-escalation from trained crisis counselors over the phone. But these 988 soon to be 988 call centers, the Georgia Crisis and Access Line centers, they can deploy mobile crisis teams. So they have GPS location to figure out which mobile crisis team is closest to the individual in crisis and is available. So they are able to deploy that. And as was discussed here, we want to, efforts in Illinois are to make sure both 911 and 988 can deploy those mobile crisis teams, which is absolutely crucial. We don't want to waste precious moments having to go through 911 to be able to deploy those mobile crisis teams, which a lot of states are having to figure out because their laws require 911 to do that dispatch. They also have a live bed registry to see which facilities have available beds in the state. And as we all know, emergency department boarding is a serious issue. And I saw somebody comment earlier, absolutely devastating, that a 9-year-old has been waiting for weeks for a bed. We should not have to do that. So this live registry is really helpful to see where are beds available and when they come online. But as Hugh mentioned earlier, there are a lot of steps in place before we even get there. The goal is to get people help and keep them in the community. So ideally, we will go through these other steps of the crisis continuum of care and actually reduce the need for people to have inpatient services. One thing in Georgia that is absolutely wonderful is that they can make appointments for individuals with community mental health providers, same day, next day outpatient appointments. So they have a centralized system where they can see availability and schedule those. It takes a step out of the hands of the individual to have to then follow up with a number they may have been given. It's really amazing that they are able to do that, and something we'd love to see in more places. And since these call centers can de-escalate 80 to 95% of calls, they're dealing with the acute crisis of the person right there, then and there. So they may be able to de-escalate that crisis, but we know there's a period after that that people are vulnerable, and we want to get them help to make sure that they get well and stay well in the community. We don't want people to cycle in and out of crisis. So being able to make sure they're connected to community mental health providers and get the long-term help they need is absolutely vital. And they also do a lot of follow-up calls with individuals to make sure, check in with them. Is there anything else they need? Were they able to get to an appointment? Really see how people are doing and provide additional services if needed. As we just talked about, texting for 988 is still something that is a work in progress. It will be available July 16th. Mental health community fought for that to be available because we knew people were going to text 988, whether it was online or not. So that will be available. But not all call centers in the 988 network will have that capability. So they're going to be addressed in a different way and not necessarily going to those local call centers yet. The long-term goal is that texts do go to local call centers, but call centers need to build up that capacity. In Georgia, they have an app that includes text and chat services for youth, My GCal app. So that's something, again, where they have been working on this, and that's something that they're able to provide to people in their state. Go to the next slide. So Colorado, mobile crisis teams, they've done a lot of really wonderful work in Denver. Denver started the STAR program, Support Team Assisted Response Programs, on a pilot basis. They started in just a few precincts of Denver, with a 6-month pilot back in 2020. It has been wildly successful, and they have expanded it citywide and are now going to provide grants to other communities in the state to start up other model programs. There was actually an evaluation study that came out just this Wednesday that showed incredible results. So they classified offenses as star-related and non-star related. Star-related were nonviolent offenses that we typically see associated with mental health crises. It may be somebody who is using substances or alcohol, indecent exposure, somebody who noise violations, a whole wide range of nonviolent offenses that were considered relevant to what the STAR program does. Law enforcement was dispatched to any incident that may be indicated as a violent offense, where there might be a weapon involved or something else that was related. They found a 34% reduction of nonviolent crime. Importantly, they saw no increase in violent crime. So a lot of times the argument is, no, you have to have the police response because, if people don't have police at these lesser offenses, then they'll just escalate their behavior. This shows that there is absolutely no correlation with that. There was no increase in violent crime as a result of having the STAR program in place. There was also significant cost savings. The average cost for dispatching the STAR program was $151 per response compared to about $650 for police response. So not only is this more effective because it gets people connected to mental health help, it's less traumatic, but it's also a lot more cost effective. So there's really strong evidence here that this is a type of response that we have all known has been really positive, but now we have a lot more hard data to show that we actually can reduce justice system involvement, reduce nonviolent crime, reduce costs, and provide people a much more humane and better outcome.
Yeah, I just want to jump in because as we begin shaping our statewide advocacy agenda, the 590 teams, we're in the mix. But to scale up, we're talking about investment and system building. And so being able to point to tangible, hard results and cost savings is incredibly powerful. And I think the reason I'm sort of making that point right now is that we do have we have data holes in Illinois. We don't know, costs. We haven't, it doesn't exist yet. UIC has got a big contract to begin getting at some of the money issues, but we can point to this right now. So as we begin shaping materials, we work with NAMI Colorado. We can get their data, but I think just want to make that, this is useful to making the case for more. So, anyways,
yeah.
Didn't mean to interrupt it. So.
No, I'm glad you did because I want this to be as relevant as possible. And I think, this is a university study, peer reviewed. There's a lot of really strong data in here, and we'll make sure that you have it. But again, there are a lot of data holes, not just in Illinois, but across the country, that make it hard to advocate for these things because we don't have as much strong data because it just traditionally hasn't been collected. And part of the STAR program rollout is that they collected all of this data. So really, really helpful that they did that and they were able to have this evaluation study. Again, it studied the first 6 months. They have expanded this program. It is citywide. And obviously it went beyond 2020 and it is now operating at a much larger scale. But that evidence has been really strong. So if we could go to the next slide, Tucson. So Tucson, Arizona is really kind of the gold standard in how this system can operate. The Connections program in Tucson has really been a leader in and how to incorporate all of the components that Hugh and Andy and Rachel talked about. Not only these call centers, but mobile crisis teams and crisis receiving and stabilization facilities. And they too also have really strong data, less about the cost savings, but more about how many individuals they can help at each point in the process. Just to give you a little bit of insight. So their estimates are that 80% of calls are resolved over the phone. For those calls where a mobile crisis team is dispatched, 70% of those are resolved in the field. So those individuals do not need to be transported anywhere. For individuals that are brought to their crisis receiving and stabilization facilities, 60 to 70% are discharged back into the community. And of those individuals who are discharged, 85% remain stable in the community for a period of 45 days or more. So it's really compelling data that this helps individuals. There's decreased use of jails, emergency departments, and hospitalization. And at any point in the process, law enforcement and 911 can hand off an individual in a crisis to the mental health crisis system. Specifically, their crisis response center, it's 23-hour observation and stabilization. That's fairly typical for billing purposes. Anyone can walk into their facility. You do not have to have pre-approval. You do not need to be brought there by 911 law enforcement or mobile crisis teams. Anyone can walk in for help. They also provide law enforcement drop-off. No matter what, law enforcement is always going to be a part of this because people are going to see somebody exhibiting behavior that scares them and not know a person is in a mental health crisis, and law enforcement will be engaged. This really incentivizes law enforcement to hand off to the mental health system because they can turn around within 10 minutes. When a law enforcement officer brings an individual to an emergency department, they have to wait until that individual is seen. So they're often there for hours and hours and hours. This way, they can be off within 10 minutes and the individual is getting much better care and more immediate care. Ability to pay is not a factor here, and any type of condition can be addressed. So that could be intoxication or drug use, suicidal ideation, if a person's experiencing psychosis, if there are other physical health conditions that might be related to what's going on. They have a lot that they can do within this facility. It's really a world-class facility. I will note Arizona is pretty unique because it is primarily Medicaid funded. They're unique in their Medicaid structure, so it makes it easier to provide all of this. But is an example that when you have all these pieces in place, it works, and it works extremely well. If you go to the next slide. So I know we already talked a lot about funding, but I want to hammer this home. There is a patchwork of funding that needs to happen for all of this to be possible. So there are federal dollars that are going down to the states. Every state receives a mental health block grant. A portion of that has to be used for crisis services. Just this year was the first time that the federal government provided any funding to go to these local call centers as part of the Lifeline network. It's a one-time grant. I believe Illinois received about $4.5 million as part of that. That just came out. We are advocating for more federal funding of these local call centers to help offset those costs and make sure that all states can build the capacity to answer all calls within their state. There's definitely a role that the federal government needs to play here in providing more resources to states to provide best practices to really make sure there is equal footing as a basis across the country. States have flexibility to use a lot of these funds to implement what makes sense for their communities, because as I said, every state is in a different place of what's already existing. So that's going to differ a lot from state to state. One thing that Andy mentioned is, telecommunications fees, monthly fees on phone bills. And just on that point, when 988 was passed, it allowed states to implement these monthly fees. And this is actually how we fund 911. And I know there's, some question about how 911 fees are used in Illinois, but this can generate millions and millions of dollars for the full continuum of crisis services, not just call centers, but mobile crisis teams and crisis receiving and stabilization facilities. On average, a person pays $1 in 911 fees every month. It varies, it's higher and lower in some parts of the country, but if we look at them across the board, the average is $1. So this is really a way that we can bring a new funding stream into the mental health system, which is a very rare thing. I will note it hasn't been leveraged to the extent that we had hoped. There has been some opposition to it. Typically, we're looking at 20 to 50 cents per user per month. 20 to 50 cents on a phone bill added each month. We also, insurance coverage is a big issue here because not mobile crisis teams and crisis receiving and stabilization facilities, not all of their services are either billable to insurance or covered by insurance. So I'll dig into some examples where that's being improved. So if we could go to the next slide. So Washington State. Washington is one of the 4 states that has put that monthly fee on phone bills. Their fee is 24 cents a month. It increases to 40 cents a month next year. And it's expected to bring in about $45 million a year. That's a significant amount of money to fund, again, not just call centers, but that continuum of crisis services. Washington also passed a law this session that requires insurance coverage for behavioral health emergency services. Now, we've been working on a similar bill at the federal level, the Behavioral Health Crisis Services Expansion Act, mouthful, to set standards for behavioral health emergencies and require insurance coverage of those standards. But Washington was able to move forward on this at the state level. So that's a very significant thing. But they're not stopping there. They've also included state general funds beyond those phone fees to expand crisis stabilization services. So they have done a lot of investment here. And on the phone fees, let me just say one thing. We did a public opinion poll in October of last year, and we found that nearly 3/4 of adults surveyed are willing to pay a small monthly fee on their phone bill. And once they found out that they already pay one for 911 and how much they typically pay for 911, more were willing to pay a fee to fund mental health crisis services, and they were willing to pay more money. So I think a lot of this is an education effort to let people know that this is a common mechanism that we already use, and it can really bring in the resources needed to build the crisis services that we need.
Quick question, Hannah. Is the monthly 24 cents on cell phone bills as well, or just landlines?
It's on all, both landlines and on cell phone bills. And most of the proposals that we've seen, so in Virginia, Colorado, Nevada, and Washington, it is on all types of phone lines. I believe Virginia also has a small point of sale fee for prepaid phones. So I think it's 8 cents when somebody purchases a prepaid phone, that they pay 8 cents for that as well. But there is obviously many more mobile phones that are in use. There's still a lot of landlines, but mobile phones are growing at an exponential rate and continue to. So making sure it applies to both is absolutely critical. So part of this is really about how we divert people from the criminal justice system, from emergency department and hospitalization, but also how we ensure equity and how we ensure that people with lived experience are empowered and part of this system. So I'm going to share a few examples of how states are doing that. So New York is one example. They passed their state budget bill, which included a lot of 988 provisions. And they really focused on increasing access to culturally competent and specialized services. So they required, you can see some bolded text here, sorry, it's very small, that 988 call centers serve high risk and specialized populations. So they called that out specifically. And they included training requirements for providing linguistically and culturally competent care. So that is something that all call centers in their state will have to receive training on to ensure that anyone who is calling is receiving care that is culturally competent and accessible to that individual. So that's something that we think is really important to call this out and make sure that this is explicit in the creation and funding of any 988 and crisis related services. And New York is the only place that we have seen that explicitly called out.
You know, one point I want to make is it's more than just doing training, it's who answers the phone. And as we know here in Illinois, and I'm sure this is true everywhere, but huge workforce issues. Illinois is actually at a good point right now where workforce has traction, especially the peer workforce. There's lots of projects that are going on to open doors for people who have lived mental health experience or have other community experiences. So this is going to be a good opportunity for Illinois to bring more people who reflect Illinois into the mental health workforce. So it's not just training. We can train anybody, but the fact that we can get more people into the field that truly reflect our state will be. We have good opportunities on that front right now, and a lot of need.
Yeah, that's a really important point. Training is important. It is not, this type of training is not necessarily provided to all Lifeline call centers now. So it is important, but it is much more than that. I will note that when you call the Lifeline in the future 988, there is Spanish speaking option. So if somebody presses 2, they can speak to a Spanish speaking crisis counselor. There are also translation services in about 150 other languages. But as we know, that translation, having a translator on the phone creates just additional time and potentially frustration. So one thing we've really been encouraging is that localities think about the makeup of their community. And if there is a large population that primarily speaks another language, to really focus on hiring crisis counselors that speak that language so that they can provide services in a native language for people who might be calling. That's just one way. Again, the crisis counselors that make up these Lifeline call centers need to reflect the communities that they're representing. And really focusing on that is going to be core to success. And if we
That's
look
one
at
issue that a lot of local NAMIs are working on too. I mean, our Sharing Hope, Comprendo, Esperanza pilot, these are NAMI programs, but the idea is to begin building networks in our community, in our NAMI communities, that truly reflect the neighborhoods we serve. So those things, those door openers, are ways for us to build relationships with people who really are the talent base for this workforce.
Yeah. That's so important, and creating that pipeline is critical. You know, something else that New York put in their budget bill is a comprehensive list of reporting metrics. So they're looking at length of time taken to respond, the types of requests they're receiving, mobile crisis teams that are dispatched, number of individuals engaged by a mobile crisis team that are brought to an emergency room, number of individuals that are transferred to law enforcement, and then age, gender, race, and ethnicity of the individual, because they really want to see, one, are we meeting our goals of reducing the criminalization of people with mental health conditions? And they want to answer questions like, are Black and brown people being disproportionately impacted by a law enforcement response? And only by having comprehensive data can they ensure this system is working as intended and serving everybody in an equitable way. So, you know, having comprehensive reporting, both reporting metrics and reporting mechanisms, is really important to ensure that this system is meeting communities' needs and truly changing the paradigm around crisis response. And then just my last slide here, I want to talk about peers in 988, because peers play such a pivotal role in an effective crisis system. And there's a few ways that peers need to be involved and are involved in a lot of states. First, lived experience should be taken into account in every aspect of a 988 crisis system. And so we have been advocating, and many states have ensured that NAMI is at the table for any permanent decision-making bodies, but that also that lived experience is infused in process development and decision-making elements of different aspects of the crisis system. One example is in Massachusetts, they do have peer representation requirements on their implementation and advisory bodies. Washington's law that created their 988 efforts also had peer representation requirements. And at the end of the day, we want to make sure that these systems are more transparent and accountable. So having these reporting requirements that I mentioned in the previous slide are really important. I think one other way that we've seen peers being leveraged as part of a crisis continuum is really to address that workforce element. So Colorado's call centers have a peer-to-peer warm line integrated in it. It's part of the Colorado Rocky Mountain Crisis Partners continuum of care. And so that's really important to make sure that there is somebody that folks can talk to that understands their situation and may have had a similar experience. They're often transferred to those warm lines after the crisis is de-escalated, but it's a really important part of their continuum. Also, we often see peer support specialists as part of mobile crisis teams. The example I talked about in Tucson, for example, heavily leverages peer support specialists in their mobile crisis model. And at crisis stabilization centers, we also see peer support specialists serving as coaches and mentors. They can provide an example of recovery. They can really provide individuals with a sense of hope and also understanding that it can get better, and really help connect them with resources that might be effective and often are used as kind of a long-term coach and mentor in those situations for individuals. So peers play a critical part of this continuum of care, and especially as we think about how to expand the workforce, ensuring peers are part of it is really important.
I think we're at the end of our slides. I think let's go straight to the resource slide. I think we might have passed it. There you go. Okay. We're at just about 7 minutes, so I just wanted to stop and make sure that we have a chance to talk about any, handle any last questions, but also talk a little bit about what happens in the year ahead. So first of all, before we let Hannah go, are there national questions we want to bring to her? Thank you, Hannah. This is really great.
I mean, no sense reinventing the wheel. States are working on this across the country. So however we can be helpful from the national office, let us know. But you're doing amazing work. So thank you for all you're doing.
There was a comment from, I think, Jack, asking about what our legislators know. We have wonderful legislators on both sides of the aisle in this state when it comes to mental health. Mental health is one of the two truly bipartisan issues with early childhood out there, and we want to keep it that way. What's really exciting about seeing what's going around the nation is that it's not partisan. It's, there are differences in where people are, but it's not necessarily partisan differences. So I think one thing that we need to do as advocates is begin educating our lawmakers. Some of our lawmakers are, the mental health committee members are the obvious first targets. Mental health committee members happen to coincide very nicely with the NAMI community. And they are really key leaders, but we should not assume that they know this. They don't. So one of the reasons I wanted to have some national stuff on is we sit in on call. I sit in on calls once a month with other with other states working on this. So we will begin collecting greatest hits, but part of the advocacy that begins next is meeting with our legislators. So did we, yes, and yes, we will send out the slide. And is the phone tax the main way that other states are funding programs? It seems to be most common, but Hannah, is that?
So only 4 states have passed those phone fees, and the states that have passed it also have state general funds that they're using for crisis services. So it's kind of a both and. For states that haven't passed those phone fees, generally they have appropriated state funds as part of their budgeting process to fund these crisis services. The struggle with that is that's often money you have to go back to the legislature for every budget cycle, and can be prone to cuts or when the economy is bad, for that money to go away or be significantly reduced, whereas these phone fees are a stable source of funding, which is one reason we're advocating for it.
Okay.
There's some other interesting, I think, to Hannah's original point of grading revenue streams, I think it's really important to think of like a sustainable funding can has to mean a few different things. Appropriations are hard, fees are hard, but there are things. The Kennedy Forum Illinois has even been talking about things like looking at the private insurance code to expand private insurance coverage of mental health crisis specific services. Because right now, Medicaid will cover mobile crisis response teams, but a lot of private insurance won't. So basically, Medicaid is subsidizing people with private insurance. So there are things, and that's in Illinois, right? So there are things like that I think there's a lot of creative ways to get to a sustainable structure.
Well, that's also one of the reasons we asked for Washington as an example. I think that's where David has found that. That's working with the insurance commissioner or the Kennedy Forum. It's one of our close allies. I wanted to take a minute or so to talk about some of the resources that are out there and what happens between now and the 16th. The July 16th, there's been an effort. This is not, we don't want people calling 988 before it's time. There will be an announcement event on the 16th, the governor and all that. We expect that to happen. Many folks have been getting media calls already, and I think that's why we did this today. So we do want folks to get equipped and get on, message, but also to share that information. What happens after will be more of a campaign mode, but right now, there's a long way to go. This is a long-term campaign for all of us. So you can find the national organization has been great at assembling very great resources. We are working to sort of develop the parallel here in Illinois right now, just in terms of places to go and find out stuff. IDHS is, that's the state of Illinois. We have to stay on that and participate in that as much as possible. There is a link to the crisis response team that is on the DHS website. When we send out the deck, you'll be able to hit the link and go there. But I think what we'll do based on the call is we'll collect a more complete list. We have a little cheat sheet that's lists of places to call. We'll update that and send that out when we send the deck. The other thing that I wanted to share is that, we're gonna be doing this for a while. NAMI Chicago and NAMI Illinois have been kind of anchoring the work, but this is really a NAMI, not even just a NAMI. This is a large community. This is the mental health community. So Rachel and I are available to sort of connect in. One thing we have set up is, we set this up last year, advocacy@namiillinois.org. We'll add you to our list, but I think the important thing, because we have local affiliates, is please put your zip code, and if you put your full address, that's best, because when we can match you to your legislators, but we'll also share that with the affiliate that you match with. Then the other thing I would say is follow social media. We've had somebody working on social media, and Rachel, they do that. I think the more that we can be exchanging and following and sharing information, especially good stuff coming out of national, the better. So more to come on that. We are at 11:30. I am happy to hang around for a few minutes, but I want to make sure that everyone has the opportunity to leave on time. So I especially want to thank Rachel and Hannah for doing this. I mean, NAMI Illinois is, we all, we're growing, but we have some vacancies, and so the willingness of others in our NAMI alliance to contribute to the cause is really an important thing. So as we do the storytelling and the media, we're looking to bring in things like messenger training, media relations training, so that if you have stories that are out in your community that illustrate one or more or all parts of the, the crisis vision that we have, give us a shout, because that's something that we want to begin brokering across the state of Illinois. And so more to come from newsletters and websites and social media and all of that, but I just wanted to thank everyone. And
maybe can I say one thing before we close?
Sure.
It's just to say, and thank you so much, Andy, and Hugh for organizing this. I just want to note that if anyone is walking out of this training feeling like they still have unanswered questions, just know that some of this is because some of the questions are still, the answers to some questions about these systems are still being developed in the state of Illinois. And so it's really important that advocates and providers have voice into this, and that we're passing along to DMH and other leaders the questions that need answers about what's going to happen and what to expect. And so please do also contact Andy and I if you are leaving here being like, but I'd really like to understand more about X. We will be sharing some of those questions at some point with folks in the government, and the more voices that we can represent, the stronger that our voice can be. So thank you all so much for coming on from my team, and I know from Andy as well.
Yeah, thank you, Rachel. I mean, that is true. The state of Illinois, I mean, they have a gigantic task before them. So the questions and the stuff that we're gathering, we are there to help. You know, we are all there to help. So, but we can't do it in isolation. So thanks, everyone. I think we are adjourned. All right.
Thank
Bye,
you.
everybody.
And Andy and I will hang out for a second if anyone wants to pop in with a question. Maybe we can end the recording. What do you think, Olivia?
That'd be a great idea.
Sounds good to me.